Assalamu alaikum. I hope you've been good. Thank you for coming in. As always, my name is Dr. Muhyiddin Mohammed. Big thanks to Kesh and Ilara for helping us achieve this, what we have here today. Thank you guys for turning up as well, because I know it wasn't easy, and thank you for being patient as well. So, main reason why we're here today is regarding the talk, basically a health talk, where we will be joined by a gentleman who has been through. He says a lot of shit, but he has been through a lot of stuff. I'd put it that way. This is a guy who has been through the corners of DRC Congo when there was, and where there still is, war going on. This is a guy who has been through up to Gaza. A guy who has been to, think of it, all different corners of life. He's a critical care specialist and cardiac intensivist. So I'm hoping that by the time we all leave here, there is something we would have picked from his experience, from all he has seen through the walk of life, and what we can be motivated about regarding life in general. So thank you for coming. You can start too. Elias, you're good? All right. So, Bismillah. Doc, why are we here? You put it better. Why are we here today?
We're here to talk about the common issue of the patients, comorbidities, chronic diseases, and the disease that they have. So basically, what you introduce to the audience, it was about heart disease and high blood pressure. But let me put it other way, because I believe in a decade, there was a lots of CMEs, there was lots of educational talk about how to prevent high blood pressure and diabetic, obesities, how to prevent heart attack, but we never come across to talk about what is, if the incident happened, what is the patient gonna go through it? What is afterwards? What is after heart attack? Yeah, so we never discussed that. What family gonna go through it? What are the financial crises that the patient gonna face? And where people gonna go? Yeah. I believe, well, I've been in a war. I'm a war doctor, but I believe that humanity is dead.
When you say humanity is dead, what do you mean?
Among us, a doctor, because we turn the healthcare to the business.
To the business side.
Healthcare, it is a business, but business in a way of proficiency. That you're selling an expert, that you are good at it, you be able to deliver adequate care for the patient care. Are we?
My question regarding that is, when people make healthcare a business, are they doing it because of the proficiency and the skills that they will bring to the table? Or is it like a more of a scam where you see many startups coming in because of that?
Well, I don't believe everybody coming up for the quality. That's where I come from. In fact, we were in a camp yesterday with your brother. In the camp yesterday. And there was a gentleman who approached us. We done the echo for them. We done check the BPs and everything for this gentleman. It was a 50 years old male who was working for some type of facility that the insurance wasn't able to cover him up. Of course, the family was surprised that he have a blood pressure, but they knew that he have a high blood pressure. Yeah, his BP was around 220 over 110. So we just joked with him, do you want to meet Jesus today? Yeah. So basically, after the daughter left, he started opening it up that he's not able to buy the drugs.
And to be specific, I'll just specify because I'll take it
you
as a
can.
podcast. Yeah.
Go ahead.
Which medication was this?
Well, we didn't give him any medication, but what he was able to afford, it was just amlodipine, but he needs to have at least 4 to 5 drugs to avoid stroke or heart attack. Was he, my question for him or for myself, yeah, we as a doctor, before we approach any patient, we have to put ourselves as a patient, right? So the feeling that I got that time, or even I told Ilyas, don't you think that he knows that he's going to die? Of course he knows, but he cannot express it because he already accepted that he cannot afford to pay these drugs. And he knows that he have the disease, but he's in denial, according to the family, but he's already accepted. It is what it is. Yeah. But generally talking, back to that topic, it's not that people, they don't know what to do. It's not that patient, they don't know what is the best or what is not the best for them.
Do you think a lot of information has already been relayed to
I
people?
believe so.
And I think you guys should participate on this because if you truly know what a disease process is like let's say I have high blood pressure, what would it mean to me in the next 10 to 15 to 20 years? This is where your opinions come in and you tell us, do you understand the implications of this? Okay, so continue.
Very.
We were talking about, do patients understand?
So yeah, but that, I believe people know. People know what is bad for them, what is not bad to them. As I said, it's been a decade that is being educated to the people, what is good for them, what is not good for them. But what I believe the patient, they don't know, what are the consequences that it comes and how they're going to face it. Let's say somebody got heart attack. What they going to do? They're going to go to the hospital, right? Nearest hospital, right? They go to the nearest hospital, they're going to see by a GP or the specialist there, and they're going to say, okay, your family member have a heart attack, be requiring to have $500,000 down payment. Are they ready for that? Let's say it's a silent killer, yes, but you mean there is no hypertension in a village?
It's always there.
So that means healthcare is for only rich people. So what if the patient cannot afford $500,000? What will happen? And what is my role as a doctor?
I think this is where the questions are important, okay? Because it opens up a huge portal that puts responsibility on all of us.
Of course. And we're going to on a strike. Why? You see, again, I work with the army. I was in a position that I was since my friend died next to my hand by the sniper. It was not my job to be in a war zone, but that's what I was passionate to do. That was my choice to do. Can we say it? We post on our Instagram, pray for Rafah, pray for Palestine, but on the ground, we're not doing anything for our own people. Does it make sense? We don't see our people on the ground, how are they suffering? Yeah. So we don't see that. Can we just go fast as a Muslim or as a Christian or any religion? We can do that, but we go and rip the patient off. In short, we just steal the money because doing these ABCD because I want to make a business, then I have to certain amount I have to get the patient money. So anyway, go back to the topic. I believe the area that we are on, if you don't have insurance, you are dead.
What do you mean when you say that? It's because majority of Muslims don't believe in insurance.
Of course, but some of them they because not everybody might believe. But let's talk about non-Muslim, right? So I believe critical care in Kenya been betrayed a lot.
How?
For me, as a role of critical care, and I've been working for 10 years, I feel like my hands been tied. In fact, in a way that billing is already affecting my job.
The financial aspect
of course. Don't do, for example, I wanted to do this type of procedure for certain patient, but I'm not able to do it. Why? Because I'm restricted. I am restricted. And what would be my role? How will I sleep? Yeah. In the end of the day, we have to think about how many people we try to help, how many people we tried to assist them. But in the end of the day, some people might think like you done your job and it's end of it. The rest, give it to the other facility to take care of it. But that is not. We cannot lie to ourselves. Not everyone can come and confess to you that the procedure I done killed the patient. We're not in that level.
Do doctors usually take that responsibility, though?
Definitely not.
They
No,
don't.
of course, because of the legal issue, because of we lie to ourselves. We are arrogant. Not us, not all of us.
I know we are arrogant towards each other, but
yes,
do we tend to be arrogant towards patients as well?
somehow yes, but not providing enough information to the patient. we don't give the consequences of everything happening to the patient. For example, we had a heart attack again. We go back to the stroke. Yeah.
Mm-hmm.
Patient relative will ask you, "How's the patient?" What would be your answer? Well, say the patient is not doing well, but still, patient is in ICU, right?
Mm-hmm.
In end of the day, you as a doctor, you know this patient will require to have a long-term facility, meaning he's gonna be at home, home care base. He's not gonna be able to walk. He's not able to talk. But you're still gonna give him a promise.
It will come up one day.
Will he? No. And patient will die. But how do you feel like? How do we?
Is that a problem because of miscommunication, or is it because people want to capitalize and make money?
It's a business. This is a cartel of the business. How we make money out of dead body. Because if the relative knows, yeah, there are different type of patient and different type of relatives. Some can afford, some can be prepared. Let's say cancer patient, they can be prepared to take care of this patient in a long term, but they know the outcome. Time will come. Yeah, but we never say that. We say we try. Let's give some chemo. Let's give some radio.
Let's put this in context.
Yes.
Say, I'm in a hospital.
Yes.
I'm working night shifts.
Yeah.
I get a 40-year-old male coming in with the classic symptoms
Of
chest pain.
Yes.
Cannot breathe well.
Yeah.
His blood pressure is a bit falling now.
Yes.
We decide to do an ECG and an echo.
Yeah.
Shows you this is a heart attack going on.
Yeah.
You decide to put a coronary angio. That's where your limitations usually start.
Proceed with the code. Yes. Proceed with the code for the CAG. Yes.
Okay. Ballpark numbers. How much would it cost for such a person to do that procedure?
Well, different hospitals have a different price. But the matter that we have to discuss is about the time. How much time do you have?
Yeah.
The gold standard time is 60 minutes. Your blood pressure is going down. Family is already panicking. Cardiologist is away. And then billing is on top of your head. How much time do you have? 60 minutes. Can you give any medication before billing approves?
No.
Can you call cardiologist before the billing approves? No. So you're going to be stuck in the middle with the patient and relative. And what if that patient dies? Who will be responsible?
The same way you put it.
Yes.
I'd want to give it like a social perspective to it.
Mm-hmm.
As Muslims, we all know that when the time comes, it has come, right?
I disagree.
Okay.
Because I can kill you because your time is came. It's not right.
Yes. Now that's where I want us to.
You will not sue me if I kill you?
If you kill me, yes, of course I'll sue you.
So your time came.
But what I'm talking about is there's that financial barrier to it, where a family knows that this patient needs 60 minutes to be sorted out.
Yes.
If we don't do something in this 60 minutes and I don't have the money for it, now it will be a case of the angel came.
The Malcolm mode,
Yeah.
the favorite angels. Unfortunate. It hurts.
So, in cases where the money is there,
Yes.
what does it look like? You've gone into
Cath lab.
cath lab. Yeah.
Yes.
You've gone into cath lab.
So let's say patient proceeded with the
Yes,
cath lab.
yes.
Okay. So after the patient proceeded with the cath lab, there would be other.
We need to simplify this. Cath lab is a place where only it's like a mini operation room. It's an operative theater only specific for heart cases only.
When there is a blockage in the heart, they will put a catheter, they will go to your small coronary arteries there to see where the plaques or the calciums are there, then they try to remove it. It will help your heart to perfuse again. So there are different type of criteria. So let's say the patient went to the cath lab, everything is done, there would be an ICU stay. So there is a criteria that the patient might need to stay in ICU. There is a criteria that the patient kidney functions is totally shut down. Yeah, patient might require to have a bypass, but we done the cath lab already and showed triple vessel disease. Yeah, so there is always additional things can happen in critical care, and not all families are ready to hear it. Of course, it's the loved one. It's difficult to lose one, even you put money on it. But what is the outcome? Can we not do the procedure and after that we tell them, guys, this is the outcome. Outcome is poor. We done our best.
What is the total death rate per se?
Well, I cannot give you the number ratio. I'll be sued tomorrow, but it's high.
It's high.
It is high.
Question: why is it that
Mike.
is it only that in Kenya that this mortality rate is high?
No.
Why is it so?
You mean why is it not only Kenya? Why is it everywhere?
Why is it? What are the mortality rates across different countries after stenting?
Stenting, it's been high. It's been high. It's not that we're going to scare the audience. Oh, tomorrow you got a heart attack. Do not do a CAG because you're gonna die. No, there is consequences. There is a age relevant, that the age of the patient is there. There is a morbidities, comorbidity that the patient have. How many kgs the patient is? He been diabetic? How many vessels is been blocked? Yeah. So there is always a criteria. So recently there is a journal with the American Society of the Nephrology for the kidneys already published. The outcome for the obese people that they are obese. There's a noises. People with the diabetics, people not being compliant, people being smokers, the mortality rate, not in a hospital, after discharge is increased. Meaning they might come back. They might not be compliant with the drugs because the drugs also is expensive. It's not that we pay $500,000 or $1 million for a heart surgery. After that we are done. No, we still need to take medications. You cannot wean off antihypertensive. Antihypertensive is not. It's actually. I know you wanna go for the hypertension, but there is no cure for hypertension. It's just a management.
Okay.
Unless you want to do herbal therapy.
Does herbal work?
No,
That was my question.
I'm really against herbal because it makes you. That is okay. That will go to the genetic systems. It will really affect your resistance. Does herbal show any effect on the cancer?
No.
Why all oncologists hate herbal therapy? Yeah, I think we in the next topic we have to talk about certain herbal therapy that people does. People take herbal drugs to lose weight. Does it work?
No.
Why?
This is where the difference comes in.
Yes.
Do you think it's something to do with the marketing?
That is where the business cartel of the pharmaceutical comes. So let's say enalapril. Yeah, amlodipine. What is a new brand?
Sacubitril.
Yeah, that's Vimeda. That's why is the new drug is better? Of course, because previous drug when they introduced was better as well.
So it's always It's always an updated game.
Of course.
I'm sure there's a lot of people who are here, and maybe
Yeah.
the guys who are going to watch this or are watching this live would want to know, if I have started these pills, that's it. It's until
Which
the time.
pills?
The antihypertensives.
Then they have to continue with the drugs. Why there is a stigma of not stopping the drugs? You see, we always thought that death is for the neighbor.
Yeah.
Is it right? We always think neighbor will die. We never thought the death will come to us. Right? You will not stop smoking until things gets complicated. That's the time. That's a human nature. That's the brain. Right? So why do we need to stop it if it's needed to be taken? And this is what happens. That's where the scenario comes. Doctor, if we stop the drugs because my dad blood pressure was fine, then suddenly he got a heart attack or a stroke. What can I do? Then you come to the chaos criteria in the hospital. Or let's say patient is an alcoholic. Can we call him alcoholic? No. He's sick. Right? But family doesn't understand that. Family will see it as addicted. So once he's admitted in a hospital as a alcohol use disorder, and let's say he got pancreatitis, acute, second time will come back chronic on acute.
Go easy on the terms. Like, I really want these guys to understand.
Yeah, it's type term like you keep drinking alcohol and your pancreas will gonna be affected, and you know that you have a pancreas problem, right? And you're gonna go home and you're gonna drink again and you're gonna come back. What do you think about the family going through at home? Don't you think we as a doctor we don't get mad? That's where the arrogance comes. You won't tell the family what did you do? Doctor, we brought him to the rehab, but the rehab didn't work. Don't you think that also family also need to have a rehab?
I'll pose you this question, and it could be something philosophical. Is it because as humans we love shortcuts?
Well, I believe they need rehab.
No, like, is it a thing where all the solutions to the problems we have always take that trajectory of a shortcut?
Because there is always two ways. There were always a two side that we have to review. We always check the one side. One side, how to prevent high blood pressure. But other side, we didn't talk about it. How to take care of the patient who have a high blood pressure. Let's say your dad, I don't have a dad. Let's say your dad have a high blood pressure. Is the scenario at home is stable enough to not to increase his blood pressure? Yeah? Sometimes you can induce him to have a stroke because of the environment. But are we psychologically evaluated well? Aside by the patient that gets psychological evaluation in the hospital, is the families aware that this patient also have a stroke or cancer? How are we going to take care of him at home to not to stress him more? Did we talk about him? Yeah, we never had a CME. No cardiologist thought about how to take care of the patient who had a heart surgery afterwards. Nobody.
People are left to
Nobody. They go home.
it on their own.
Of course, the guy will be depressed. If you are being sick, you've been in a hospital, there is a lot of delirium and then depression that you will get. And of course, you're going to see next bed to you is already dead. Yeah. Basically, you're going to feel the angel that is coming around you and leaving you. But when you go home, do you think the guy would be the same guy? There is a studies already established about the depression after ICU admission. Yeah. And not everything is antidepressant for this type of patients. What about the family? What is the role of the family at home environment? We give you some drugs. We had a similar patient together. Right?
Yeah.
And we found out on the Holter, on the ECG we found out this patient have a PTSD. But she wasn't able to talk about it. Right? So what is the role of the family, next of kin or the family member at home? How to take care of this patient?
Yeah. So you brought in the PTSD bits, where I'm sure majority of us have at one point in time dealt with a heartbreak or relationship
Broken.
stuff. Yeah, broken heart syndrome. How does that come about?
Broken heart syndrome is basically, let's put it in another term, It's type of heart failure. But we had I contract with a few cases with the broken heart syndromes, which is mostly population was on female. It's a basically is a short-term heart failure. Yeah, and there is a reverse. Yeah, that's a good thing.
It has a treatment.
Of course, your brain controls everything on your body. Your brains controls each of your organs. So it is reversible. That was one of the topic of I think questionnaire that it was on top. I think we can discuss more about it. It's reversible, but it still requires drugs to be taken and how to prevent it. We never discussed it again.
How does it come about?
It's a psychological, it's psychological problems.
How long would it take to clear out?
Okay, if we go into that topic, how are we going to diagnose it? Yeah, there is even we put 150 CMAs for free with chakula, with free food, even with 1,000 Kenyan shilling. No medical officer will come to attend. Why? Why we not passionate to come and learn? Yeah, patient comes to in the emergency room with a headache or chest pain. I think Elias is at the background. The patient we saw yesterday, it was in a medical camp. Patient was having productive cough for 1 week, and they were treating him for pneumonia. Yeah, but this patient had a massive hypertension. His blood pressure was in the roof. He wasn't able to sleep. He was getting shortness of breath. So it's us as well, because we don't want to learn. Why? Why do you think so? Why we not motivated? You as a motivator, why do you think we as a doctor, we don't want to be motivated? You see, before I come here, your brother told me something. I'm doing fellowship for nephrology critical care. And he told me that, what do you want to do with the MCQ now? It will not make you money. What are you doing with your certificates? Well, it's true. But still, learning is a passion. But how can we address to motivate the MOs for the diagnostics? Tell me. Motivate them.
I think it all comes from within.
Sorry?
It all comes from within.
True. Is it like we're designating people in a wrong area? Can we strike while we are fully employed?
Can we what?
Can we go on a strike while we are fully employed?
No.
What will happen? They won't pay you. Then you'll be jobless.
Yeah.
So how can you go on a strike?
So the strike was uncalled for?
No, the reason again I just wanted to bring it up, is it possible the KDF, Kenyan Defense Force, while we are in a war, they go on a strike?
No, not possible.
Why? Because it's the duty
essential
to the flag of the country. So we all had the oath. If you have even 1,000 Kenyan shilling in your pocket and your patient can benefit from that, you have to spend it for that patient to survive. Will you do that? No, I do. And I lost a lot of money. But that's when it comes, then I tell you that humanity is lost. You're going to ride your car, you're going to go home in the end of the day. You're going to forget about that patient either.
What can we do to bring back such humanity?
That is a long term. We have to hear people out, because I believe they never been heard out, because I've been arrogant person. Maybe we've been arrogant as a consultant. We've been arrogant because for every small mistake that the doctors they do, we brought the chaos on them. We fired them. We never give them a chance to talk. You see, healthcare can be upgraded when there is a demand. Investor will come when there is a demand. You be working in an emergency department and you know lots of A, B, C, D, then you can demand. Me, Muheddin, I know these things. I'm demanding for this equipment to be there. Don't you think?
It's possible.
Yeah.
I'll deviate your mind.
It's a very hard topic.
It's a hard topic, yes. Because I don't think people know that I sacrificed. People always reflect to it as I sacrificed, not I want to. You get? Why am I saying this? Humanity is lost because everyone is about himself. If you look at how
Selfish.
yes, everyone is about himself. So to divert that mentality you're talking about, where I am going to do this for the sake of saving this person, that one is borderline gone. Very few people do it.
Yes. And there are some people who are still doing it.
There are few, very few.
Very few.
I'll take your head away from that because I don't think we will ever find a solution to that. I think
But that is the lead for diagnostics.
it is what makes this profession better.
Yes. Because if it doesn't make the profession better, for example, with learning, if you don't want to continue your education, let's say just a CME for ECG reading, if you don't want to pursue it to learn more about ECG, so what you gonna do? How will you diagnose patient? You're gonna send that patient home. The patient will come with a heart attack. That is a point that I'm trying to make.